Good evening to one and all. I welcome you all for this webinar. This is Dr. Rajiv Peres from Arihant Homeopathic Medical College and Research Institute, Gujarat. This is my college and I would like to thank Dr. Manish Jain, the Director of Homeopathy 360 for giving me this platform to share my thoughts on this topic, homeopathic management of urinary problems. I also thank my principal for permitting me to do this presentation before Homeopathy 360. I welcome all the teaching faculty, all the PG students, UG students, and all my friends to this webinar. This webinar is affectionately dedicated to my teacher, late Dr. Mohinder Singh Jas. Who was a grand teacher of homeopathy for 50 years. He had a roaring practice in Delhi where he was known as a kidney doctor. I thank you, sir, for teaching us homeopathy and for showing us how to treat patients and bring a smile on their faces. On 10th of September is Sir's 75th birthday. So this webinar is a birthday remembrance to my teacher. Happy birthday to you, sir, in heaven. We love you. This is my clinic in Goa where I have been treating these three cases. So the first case that I will be taking for you is a case of acute urine retention. So on the 12th of February, this 79-year-old man was brought into my clinic in the evening at 7 p.m. Now, he was brought with the complaint that he is not able to pass urine. He is only able to pass 2 to 3 drops of urine. Since last 2 to 3 days, he is having this problem, and whenever these 2 to 3 drops come, there is stinging type of pain. As a result of this, his abdomen, lower abdomen was massively distended and he was finding it difficult to breathe normally. Since the same afternoon, he was suffering from fever. He also told that he is having frequency of a urination, especially at night, midnight, 12 to 12:30 a.m. Now he was not able to pass urine in the sitting down position. Can pass urine only on standing. He is a known case of diabetes type 2 since the last 30 years and he was on oral medications for it. The same morning before coming to me, he had gone to a village doctor who conducted an ultrasound, and on the ultrasound it was revealed that he is having prostatomegaly and urine outflow obstruction. So the diagnosis was clear based on the ultrasound. So acute urine retention secondary to prostatomegaly, and he had the storage symptoms of frequency, urgency, and nocturia. So these are the same complaint, chief complaint along in the tabular form. So passes only 3 drops and then stoppage of urine, fever since afternoon, inability to pass urine, stinging pain since last 2 to 3 days, modalities worse at night, urination only in standing position and worse on sitting. Now we need to understand, friends, that what are the commonest causes for urine retention. So let us first try to understand in females. Now, these are functional causes. So the first cause is your impaired coordination, which you will get in whenever there is detrusor external sphincter dyssynergia, whenever there is primary bladder neck outflow obstruction, or in Fowler's syndrome. Second cause in functional zone in females is your perioperative. Now, whenever there is an operative procedure, maybe an epidural is used or other analgesics are used, and these tend to cause functional acute urine retention. The third point is your infective causes or inflammatory causes. The reasons for this is your urinary tract infection, genital herpes, and your acute vulvovaginitis. The fourth cause is the pharmacological cause, especially when the patient is on drugs like antidepressants, antipsychotics, opiates, or antimuscarinic drugs. Then you can have the urine retention. Now we come to the males because our patient is a male. What is the number one cause? That is an enlarged prostate. Now this is what happens after the age of 45 years. The second cause that can give rise to urine retention is your obstructive causes. There are two main causes here. One can be a urethral stricture and the second can be a renal calculi. Okay. The third cause in males can be pelvic organ prolapse. So be it a urethritis or be it edema which is secondary to her genital herpes. Then you can have constipation as a cause. Then you have infection as a cause. In males, the infection is prostatitis or urethritis or uh, a herpes infection, right? Neurological causes. In neurological causes, you have to remember that whenever post-stroke or whenever post-spinal cord injury or post-diabetic neuropathy or post-multiple sclerosis or Guillain-Barré syndrome, where you will get a urine retention because of interruption between sensory and motor innervation of the detrusor muscle. The other neurological cause where you can get um, urinary obstruction is your insufficient detrusor muscle that can give rise to your urine retention. So this is the investigation ultrasound which was done by the village doctor, which shows prostatomegaly with bladder outflow obstruction. Now almost after a month, that is on 8th of March, I have repeated the ultrasound and it showed that prostatomegaly is there, but prostate has reduced to half the size. Now, how this was achieved? Let us try to understand the homeopathic aspect of it. So this was my acute totality. Boger-Boinninghausen characteristic repertory was used. The first symptom is the causation which I have considered, that is the prostate gland enlargement. Second is urination, drop by drop. Third is your micturition interrupted. And the last one is from the knowledge of Materia Medica, can urinate only when standing. So only two drugs, conium and sarsaparilla. But if you see in all these rubrics, conium is what is leading. So what are the Materia Medica references? If you see Allen's keynotes, you will find great difficulty in voiding. Urine flow is intermittent because of prostate affections. Check in Bogus synoptic key. Urine stops and starts better by standing. Prostatic dribble is seen. Vermeulen's concordant materia medica, you will find frequent urination at night, feeling of pressure on the bladder, much difficulty in voiding, and dribbling in older men. Our patient is also old. So what are the other close coming drugs? So other close coming drugs is subalcellulata. What is there in subalcellulata that is present in our patient? Look at this symptom. Starting flow of urine is difficult and painful. But why not subalcellulata? Because there is no paresis of the bladder, nor there is sedimentation in urine. In subalcellulata patients, you will find so much sedimentation that maybe the urine can be found milky urine also. Okay. Then pulsatilla. Why not pulsatilla? Because there is no emotional element in pulsatilla will get urine dribble when he is emotionally upset. That is not found here. Other thing is everything happens in pulsatilla after urination, be it the spasmodic pain, be it hematuria, which is absent in our case. Third remedy is sarsaparilla. Why not? What is there in sarsaparilla that is there in our patient? That is can pass urine only when standing. But that tenesmus of the bladder is not there. That severe burning at the last drop of urine is also not there, nor screaming is there while passing urine. That's why sarsaparilla was also excluded out. Now, one point I want to tell here about a clinical tip. See, whenever you have symptoms which are worse at the end or severe at the end of urination, what does it suggest? It is suggesting nothing but the cystitis. So pain at the end of urination is suggesting an infection up in the bladder. And suppose if you have symptoms like pain in urination, worse at the beginning of micturition, as we found in Sabal cerulata, it is suggesting that the infection is lower down in the urethra, that is urethritis. Okay. Another point I want to tell here is suppose you have flank pain or the lumbar pain, back pain on one side. What it shows? It shows that the it indicates that the upper urinary tract is involved. What suppose if fever is present? Fever will indicate that there is an invasive infection either of the kidney or of the prostate. When we see fever, we need to consider pyelonephritis, which is of two kinds. One is mild, wherein you will get low-grade fever. There will be low back pain at the costovertebral angle pain. Okay. If it is severe pyelonephritis, you will get high-grade fever with rigors, with nausea, with vomiting, and with symptoms of cystitis you will not find. Suppose if this same fever goes for the continuous type of fever with bacteremia or bacteriuria, then you have to suspect that this pyelonephritis has become complicated because of intraparenchymal abscess formation. Okay. Then we come to the last drug, that is staphysagria. Why staphysagria was excluded? What is the symptom which is present in staphysagria, present in our patient, is patient uh, urinates in thin stream and drop by drop. But why staphysagria was ruled out? Because there is no burning in urethra when not passing urine, and this is not a young patient, right? So what is our final prescription? Conium maculatum LM3 was used, 8 drops every hour. So why LM potency and why this much repetition? See, LM potency is having depth. At the same time, it is acting very quickly. This is an acute crisis, and that is why we require to repeat every hourly in order to stimulate the response pattern in this old patient who's having low susceptibility. Why do I say he's having low susceptibility? Because he is having acute urine retention for last 3 days and still he's at home, and now his daughter-in-law has brought him. So this shows that his reactivity, his susceptibility is low. So this I have mentioned. So now we will see the follow-up. So he came on 12th. Prescription was given in the evening at 7 p.m. Conium maculatum 0 by 3 every hourly. So 8 p.m. he received, 9 p.m., 10 p.m., 11 p.m. At 11:30, he passed 1.5 liters of urine. Then by 12, he went to sleep. At around 5 o'clock again, that is on the 13th morning, 5 a.m., he passed 1 liter of urine. What this shows us that the remedy has got registered. So what I have done is I have tapered the dose from every hourly to 3 times a day, same medicine. After 2 days, he came with complaint of stinging pain, 5 times urine at night. I advised him to do a urine routine test, which came normal. Then I told you after nearly a month, we have repeated the ultrasound. This is the follow-up. PSA is normal. No episode of urine retention. Yes, more urination at night compared to day, right? This is the phenomena of prostatomegaly. So although there is amelioration, for the last 8 days he had not taken 0/3 medicine. So susceptibility has improved as compared to before, but we upgrade further. We prescribe conium 0/6 every alternate day now. So these are the investigation. On the right side, you have the PSA, and this is the urine test which came out to be normal. So this is the further follow-up. So next month, that is in April, he came again. This time he was saying he is having strong smell in urine, more urination at night, frothy urine indicating proteinuria, gas in the abdomen, which is better by flatulence. So new symptom is offensive urine. Change in the totality is seen due to the increase of the diabetes. So lycopodium 200 was given, one single dose. Immediately after 2 days, he came for the follow-up non-odorous urine. 6 to 7 times he's passing urine at night. Okay. So overall, he's better. So no new medication was given. After 1 month, that is on 20th of May, he came back and FBSL is 9.6. Occasional difficulty to pass urine. This shows what that patient was better here. Now he may relapse. So disease is still lurking. So I decided to give conium, but now still in less repetition. That is 1 dose per week. And for this was advised for 2 weeks. Now this is a chart which shows us frequent micturition. What is the first cause here? That is nothing but your prostatic hypertrophy, right? In urinary tract infection also, lower urinary tract infection also you can get it. In urethritis also, okay? This is the investigation report which is done on 16th of August 2022. Here you on the left side you have urine examination which is showing pus cells of 35 to 40, and on the right side you are having ultrasound report. Now this is showing grade 2 prostatomegaly. And this is the follow-up on 18th of August. He came with fullness in the flanks and abdomen. That fullness is better by fasting. Cannot pass eructation, would feel better if he would get an eructation. Feels irritated, scolds wife whenever his things are out of place. Constipated, hard stool, no problems as of in passing urine. And on from the left eye, there was lacrimation and agglutination on the morning, only in the left eye. Again, can pass urine only when standing or more easily when standing. So here the new symptom is your GIT affection. Pus cells are there, but there is not symptomatic because urine pH was all right. Okay. So change in the presentation made me to give Nux vomica 10 ml one single dose. So why Nux vomica? Because Nux vomica is an antisoric covering the acute totality, and other reason for this is we have to go miasmatic now, because see, initially there was improvement, the prostate size reduced, but 6 months later when you consider, you come to understand that from the dimensions of the prostate have gone from prostatomegaly grade 1 to grade 2. So in the long run, best selected medicine conium has also failed to hold the case. The same problem which Master Hahnemann encountered, that there are relapses which are happening. And here comes the role of miasm. That's why I have selected Nux vomica as an antisoric. And plan to go next is to stay with conium 0/9, LM9. So what this case taught me as an acute learning, that catheterization is not the only way out for treating urine retention. That if we try homeopathy, then we will be able to relieve the patient. And LM potencies are very effective in such type of cases. Now coming to the medicine proper part, what is dysuria? Dysuria is nothing but the painful urination. There are two symptoms which will indicate to the lower urinary tract. One is bladder pain and the second one is dysuria. Now we need to know what are the things that can give rise to dysuria. See, let us first consider the females. Now, in females, the first cause of dysuria is nothing but bacterial cystitis. What causes bacterial cystitis? Your E. coli and Staphylococcus saprophyticus. What is the onset? Acute onset. Okay, and what you will have as symptoms? You will have frequency, you will have urgency, you will have suprapubic pain, and you may have hematuria. So these are the four signs of bacterial cystitis. Then you have also lower urinary tract. Point number two, lower genital tract infections like vaginitis. Now, what causes vaginitis? This is the sexually transmitted organisms which are causing this. In whom you will find in younger women who are having multiple sexual partners who are not using the condoms. So here you will have also dysuria, but this will be a gradual onset dysuria as compared to the acute onset that you find in bacterial cystitis. Okay. So other symptoms will be same urinary. Frequency will be there. Suprapubic pain will be there. Dysuria will be there. And hematuria you will hardly find. Hematuria you don't find. Then you have also uh, vaginitis. In vaginitis, you are going to find very offensive discharge from the vagina that is caused by nothing but your chlamydia albicans and trichomonas vaginalis. Okay, and you will also have infection and itching in the surrounding region of the vagina and dyspareunia, that is your painful intercourse. Now, what if it is a third point, that is the ulcerative lesion? In ulcerative lesion, you are going to find in your herpes simplex virus. Okay, now we come dysuria in males. The first cause is your acute bacterial prostatitis. Now, acute bacterial prostatitis, this is caused by E. coli, and due to this, there will be fever and chills. So you will have the other symptoms like dysuria, suprapubic pain, frequency, and you will have hematuria. Okay, and it will be acute onset with fever and chills. What if it is chronic? Now, when you have recurrent episodes, we will call it chronic bacterial prostatitis, which will be associated with perineal pain and the pelvic pain. Then the third point, that was the case in our case number one, that is your BPH, benign prostatic hyperplasia. So this is what happens in the men above 45 years of age, and you will find three important symptoms. What is the number one symptom? Number one symptom is the stream of the urine will be very weak. Even in our patient, the stream was very weak. It was so weak, he was not able to propel the urine out. It used to fall on his thighs and run down his entire leg. So weak stream is the number one sign. Second thing is hesitancy. Whenever he used to go for an ultrasound, they after checking ultrasound on full bladder, they used to ask the patient to pass urine and come back to find out post-voidal urine. So he was not able to pass urine. That symptom is called as hesitancy. That was also present in our patient. And the third symptom is your dribbling. Now, dribbling was also present in our patient. So these are the three signs of your BPH. So next we come to urinary tract infection. What is urinary tract infection? Urinary tract infection is, comprising of a variety of clinical entities which start from your pyelonephritis, that is originating up in the kidney, which can be asymptomatic variety also, that is asymptomatic bacteriuria, can go up to cystatitis at the level of bladder infection, and go up to prostatitis at the level of the prostate. So all these together, okay, are giving rise to UTI. Now, UTI is of two varieties, uncomplicated variety. What is uncomplicated variety? Uncomplicated variety is nothing but acute cystitis or pyelonephritis in a non-pregnant woman who is having no anatomical anomalies and who is having no instrumentation done in the urinary tract. What is instrumentation? Maybe a catheter or maybe a urinary divergency surgery. So when this is not there, then it is uncomplicated variety. So most of the women, you will find that they are having the uncomplicated variety of the UTI. What is complicated variety then? Suppose instrumentation is done. Suppose it is a pregnant woman who is having chances of pyelonephritis. That will go in the complicated zone. A person who is having delayed response to the therapy, that will be the complicated UTI. Or where there is, bacterial resistance, or where there is anatomical anomaly, those will come under complicated UTI. What are the risk factors for UTI? See, females have more chances of UTI than male. Why? Because their urethra is very close to the anus, hardly 1 centimeter. Second point, males neonates are more prone because males tend to have neonates more anatomical anomalies, and that is the reason why they are more prone. Men above 45, reason for this is benign prostatic hyperplasia. Females between 1 year to 50 years, if you do a general survey in a population, 50 to 80% of women have suffered UTI at least once in their lifetime. Let us find out what are the risk factors for acute cystitis, that is your bladder infection. Why so common? Because of increased use of diaphragm with spermicide, because of frequent sexual encounters with new partners, or UTI history in the previous 12 months, or there is maternal history of UTI, or there is history of diabetes and incontinence. What are the causes of incontinence? See, females who have given childbirth, their pelvic floor muscles become weak. That is the cause of incontinence. Maybe detrusor overactivity, that is the cause of incontinence. Or urinary tract infection, which we have just discussed. That causes your urinary incontinence. Also, neurological causes like spinal cord damage, multiple sclerosis, and degenerative diseases of the brain. Also, post-pelvic surgery, you get urinary incontinence. Now, this point we have to understand that why women with diabetes have higher incidence of asymptomatic bacteriuria or are more chances of having UTI. The answer for this is that is because of you have to consider 2 points here. Women with diabetes, you have to know the longer the time they have suffered diabetes, the more the chance of having UTI. Second, if they are on insulin instead of oral diabetes drugs, then the chance of UTI is much higher. The other reasons is because of your poor bladder function, because of incomplete voiding, because of obstruction in the urinary outflow, because of impaired cytokine secretion that will promote the UTI formation. And the last point, that is sodium glucose cotransportase 2, SGLT2. This is a drug which is used as a therapy for your diabetes. This promotes glycosuria, and because there is glycosuria, the colonization of bacteria become much easy. So they have higher chances of UTI. So we come to the one more point I'd just like to tell here is why pregnant women have higher chances of pyelonephritis. See, during pregnancy, the ureter uh, the ureter motility peristalsis goes for the inhibition. As a result of this, woman is more subjected to suffer from vesico-ureteric reflux. Hence, chances of pyelonephritis is much higher in such pregnant women. If the woman is a pregnant woman is suffering from pyelonephritis, the chance of preterm delivery is much higher, and such a baby will be formed with low birth weight. Then also anatomical anomalies, they will also uh, favor the formation of UTI. What are these anomalies? Anatomical anomalies. Suppose there is a catheter in the urethra or the bladder. That is, this catheter acts as an inert surface where the colonization of the bacteria can easily happen. This is one anatomical anomaly. Second anatomical anomaly is when there is a vesico-ureteric reflux. Third is when there is a prostate hypertrophy. Fourth is whenever there is a urinary divergence is surgery done. Okay, so these are the anatomical anomalies that will favor the formation of UTI. So see, the history in your urinary tract infection is of high predictive value. I'll give you an example. If you have a woman who is coming with acute symptoms and any of the four symptoms are present, maybe there is, even if one is present, backache is present, dysuria is present, frequency is present, and hematuria. If any one symptom is present, 50% chances are there for this woman to either have pyelonephritis, or 50% chance is there for this woman to have uh, cystitis. Okay, these are the 50-50 chances. Suppose you have a woman who's having only two symptoms out of these four. There is frequency and there is dysuria. There is no vaginal discharge. Then 90% chance that this is a UTI. There is no need to the laboratory investigation. Directly you can start with the therapy. Now we come to the investigation part. Now the first two, that is urine dipstick test and urine analysis. These are of the diagnostic tool. Urine dipstick test will tell us that this is an uncomplicated variety of your cystitis. So this is the one which most of the women suffer from. Urine analysis, what it will show? On microscopy, it will show pyuria, that is, pus cells will be present in almost all the cases of cystitis. Hematuria will also be shown in urine analysis, but only in 30% of the cases. What about urine culture? Urine culture is the gold standard as far as the diagnosis is concerned. It is having only one drawback, that the time that is taken to get the result. See, to get the result, at least 24 hours are required. Again, to identify which specific organism is present, you require another 24 hours. So 2 to 3 days, you are waiting for the result without starting the therapy. So this is how, what investigation we will do for a UTI. Now we come to a very important presentation. What is this? This is something called as bladder pain syndrome. What is bladder pain syndrome? Bladder pain syndrome is a condition which you will get in women in their early 40s and in their 40s and in the early 60s. Okay. How does it present? It will present as a severe discomfort, pressure, or pain in the bladder region. Okay. And these women are finding it difficult to start urine. They are finding it difficult to empty the bladder, and there is a bladder spasm. So there is pain. Where is this pain? Can be in the suprapubic region, which is present in 70% of the cases, can also be present in the urethra, and also in the back in 20% of the cases. So pain, discomfort, pressure, patient will present as this. Okay. So how do you say that this is along with urinary symptoms like frequency, urgency, and nocturia? The frequency in these cases can go up to 60 times in 24 hours. Nocturia is there, urgency is there. So this lady will be trying to be as close to the bathroom, right? And nocturia, so she is not able to sleep also, disrupting your daily activities, disrupting your work schedule, disrupting family life, disrupting sexual relationships. Everything is disrupted. Okay. So how do you define your bladder pain syndrome, BPS? So this is defined as an unpleasant sensation perceived as discomfort, pain, or pressure from the urinary bladder associated with lower urinary tract symptoms for more than 6 weeks in the absence of infection, in the absence of any other identifiable cause. So when you have ruled out causes like cancers of the bladder, kidney, urethra, prostate, when you have ruled out all tumors of the bladder, when you have ruled out BPH, benign prostate hyperplasia, when you have ruled out cystitis, tubercular cystitis and all other causes, yet the patient is suffering from suprapubic pain, backache, then you have to think of this bladder pain syndrome. Bladder pain syndrome is also having non-urinary symptoms. What are non-urinary symptoms? Like numbness, dizziness, ringing in the ears, blurred vision, muscle spasm. So imagine this lady, how many specialists she will visit. she'll go to the ENT, she'll go to the orthopedic for the muscle spasms, she will be sent to the neurologist. Everyone says everything is normal. So when everything is exploded, you have to think of bladder pain syndrome. Another important modality is that whenever the bladder is filled with urine, then the pain when discomfort will increase. And when after the urine is passed, then there will be relief. Also, urge to urinate will relieve the pain. There is also a concomitant here with the eating and the drinking. Many times they will have association, like milk is going to cause the uh, add on to the problem. So look at the modalities: worst by menses, worst by stress, worst by tight clothing. This remind me of our homeopathic role in this condition, because this is a functional problem, this is a psoric problem, and the modalities are fitting in our homeopathic materia medica. Worse after car riding, worse after exercise, after sexual intercourse. Okay, so this remind me also of the drug lycopodium, which is having this type of stress related symptoms. Now here is a slide of colored urine. Why I have shown you this slide is 2 days back I was a 10-year-old child consulted me for, after passing urine, after it's allowed to stand, the color of the urine would change to Coca-Cola like urine. So this is a condition called as choluria. It is happening in liver disorders where the serum bilirubin is above 1.5 milligram per deciliter. So I have shown you this because the case which is following next is going to have an altered color of the urine. So now we come to a case in a 40-year-old Balwadi teacher who had gone to her neighbor's house in the afternoon at around 2:30 p.m. And she started with this incapacitating type of pain, bruising type of pain. Okay, suddenly it started. So much so that she had to lie down on the nearby sofa, and even speaking was causing the pain. Now she is a known case of a kidney stone. This was the fifth episode of the kidney stone. So the physician asked the patient, what is the color of your urine? And she said it is a tea color urine and has a very strong smell. Then finding out the other things, the patient said that neither she can lie down, neither she can stand, neither she can walk. The pain is causing nausea, the pain is causing headache and making the patient to weep, but the patient is not able to weep also freely. Patient was not understanding what is happening to her, whether she is feeling like passing urine or passing stool. Okay. So I will tell you that by 3:45 same day, I went with the medication. I gave the medication to the patient. At around 4 p.m., that is 15 minutes later after giving medicine, patient said, I am feeling 25% relief. And slowly she began to sit up and start speaking normally. And then she started talking of her sleeplessness and how she listens to hymns and praise until she falls asleep. Then the physician went home, patient went home walking. The next morning, the follow-up was taken at 7:45 a.m., where the patient told that I'm feeling 75% better now, but if I take a deep breath, then I'm able to feel some poking pain in the left side of the back. Then the next day, day two after the medicine, at 7:30 a.m., again the follow-up was taken and the patient said that I'm 100% better. So how did this happen? What was the prescription? The prescription given was Pereira Brava 200 one single dose. What is the reason for giving Pereira Brava? It is a left-sided colic. The modalities guided me to Pereira Brava. Cannot sit, cannot stand, cannot walk. Third thing is the urine. Very strong ammoniacal urine that smells. And the fourth thing is the pain was making the patient to sweat. Uh, and it was making the patient to feel cold. So patient breaks into cold sweat. This was another indication for the Pereira Brava. So now we come to understand, okay, pain. So we come to understand what is kidney pain. Now, kidney pain is the pain which you will see starting as the flank pain. Where is it starting? In the posterior costal margin, at the posterior costal margin or below the posterior costal margin, near the costovertebral angle. So it will start here and it will go around the trunk and go anteriorly towards the umbilicus. So this is the kidney pain. Why do you get kidney pain? Because of the distension of the renal capsule. What is the nature of kidney pain? Dull pain, aching pain, and a steady type of pain. Whereas if you try to compare it with the ureteric pain, which was the case in our, just now I told you this case, that's the case of ureteric pain. The type of pain will be dramatically different. So ureteric pain, which is there, is going to start at the same posterior costal margin, and it is going to go around the trunk and ascend anteriorly in the lower quadrant of the abdomen. If it is male, it can go up to the testis. If it is female, it may go into the labrum, or it can even ascend down in the anterior aspect of the thigh. Ureteric type of pain is very severe, incapacitating, and a spasmodic type of pain because the smooth muscle of the ureter is involved. Okay, and the patient in ureteric pain will be rolling from side to side, will be very restless. He will be having vomiting. He will be having sweating, which is very prostrating. Okay. When you will get ureteric pain? When there is a stone which is causing hydronephrosis. Why stone? Because this is the solid material, that is the blood and the pus with the infection that is accumulated. Compare this with peritonitis pain. If it was a peritonitis pain, then the patient would be prefer to lie down perfectly still like our Bryonia alba. Now, even the site of the pain will guide you to the diagnosis. See the loin pain, that is the flank pain, right? What is suggesting? Problems in the kidney, be it a renal cyst which has bled or got infected, or pyelonephritis, or maybe a stone at the pelviuretral junction. If it is suprapubic pain, okay, at the bladder, it is showing you that it is a lower urinary tract infection. As that maybe there is a tumor in the bladder, or there is retention, as in our case, first case. Strangury, perineal pain will suggest prostatitis. Now, what is hematuria? Hematuria is nothing but blood in the urine. This you can see as a gross hematuria. Gross hematuria where blood is visible to the eye. In case of your ureteric colic, kidney stone, there you will find painless type of hematuria. Okay. Where else you will see hematuria, where you can visibly see blood? Four conditions I will tell you: glomerulonephritis, when you have cancer of the kidney, bladder, or the prostate, when you have polycystic kidney disease, or when there is benign bladder papilloma. In this condition, so here you have the renal causes, be it stones, be it tuberculosis of the kidney, or trauma, or you have post-renal, maybe bladder tumors and all the others. Now we come to the case 2. So this case was seen in February of 2017. This 42-year-old woman, mother of 3, she came with right-sided renal colic 3 millimeters in size. This stone was detected in the month of December 2016 by her gynecologist when she went for discomfort complaint. Piercing type of pain at the renal angle, feel better by covering the affected part. Also, she had varicose veins, which she noticed after her second delivery. She was a shopkeeper. She used to sell farm products like egg, meat in her shop. So most of the time she is standing. As a result, she is feeling heat in the sole, relieved by raising the legs up and better by warm application. There was acidity problem because she was not eating on time, be it lunch or be it dinner, and everything that she ate used to turn into gas. Also complain of piles, non-bleeding type, and burns. Piles are burning when passing the stool. Accompanying complaint was low backache, stiffness in the back, worse in the morning. Back was feeling broken. Okay. Desire wise, like sweets and warm tea, sleep, unrefreshing sleep for no reason. Chilly patient. Uh, Past history, if you see, 2 years back, she was operated for right-sided fibroadenoma of the breast. So everything is on the right side. Family history, mother is having varicose vein and rheumatism. Father died of pneumonia at the age of 67. Now, life space. She was a very pretty woman and with bag-like swelling in the upper eyelid. Very fashionable lady, going to church every day, religious, very strict on the facial appearance, and very duty conscious, family oriented woman, helping her husband to run the shop, constantly worried about her children and doubly anxious if they are little delayed to come home. By nature, very sensitive, especially if some customer speaks rudely or her husband speaks rudely, because she had a husband who was not so emotional type. So, whatever love that she aspired to receive, she never got. And by nature, she was very irritable. She will never allow anyone to take advantage. She does not mind getting involved in a quarrel, but she will, fight for what is right. Memory was little weak, forgetful for the calendar dates. So what was the prescription? So this is a very obvious prescription. This is a chronic presentation. There is no acuteness in the presentation of this case. So prescription given was thirstless, chilly, sensitive to noise, startled easily, easily excitable. What was the prescription? Prescription is Kali Carb 1 m 1 dose. This is a psoriatic case, clear cut symptoms. What is the reason for prescription? Bag like swelling of the upper eyelids, number one. Hypersensitive to noise. Finest remedy for stiffness, problems after delivery. Kali Carb is a very good remedy for stomach ulcers also, and a remedy for insomnia without apparent cause. And Kalikab is also having that back broken feeling which is present in our case. What was the follow-up? 2 months later, the patient came back in the month of April, very happy and excited, informing me that the gynecologist has done the ultrasound and the stone has disappeared. Then I asked about her varicose veins in the legs. She said, I am feeling lighter. I asked about the gas problem. She said, I am 75% better. I asked about the shoulder pain. She said 90% reduced and backache was totally absent. Piles were improving. No more medicine was given. So this brings us to the these case 2 and case 3 are cases of nephrolithiasis or the kidney stone disease. This nephrolithiasis is very common, very painful and very costly. What is why costly? Costly in terms of the surgical procedures. We know the different types of stones. The calcium oxalate stone are the 75% of the cases you will find. 15% you will find calcium phosphate stone, uric acid stone, 8%, and 1% you will find struvite stone, what we call as a triphosphate stone, and 1% you will find as the cystine stone. When do you get nephrolithiasis? See, in the ladies, in their 30s, the risk increases. Once they have crossed 50, risk decreases. If it is men, in their 40s, the risk increases for nephrolithiasis. By the age of 70, it will reduce. What are the associated medical conditions? Gastrointestinal malabsorption, like your Crohn's disease. Primary hyperparathyroidism, obesity, type 2 diabetes. These are associated with nephrolithiasis, or distal renal tubular acidosis, gout, hypertension, cardiovascular disease, cholelithiasis, chronic kidney disease. So, what one needs to remember is that suppose there is obstruction to the outflow of urine due to a stone, then this becomes a urological emergency, because this is pus under pressure and you need to re-establish the drainage. For this, there are 4 procedures. One is the urethral stenting, number one, which is done under general anesthesia cystoscopically. Second option is your percutaneous nephrostomy tube. This is preferred for the larger stone in the upper region of the kidney. Third one is the extracorporeal shock wave lithotripsy, ESWL. This is the least invasive option available. And the fourth one is your basket removal of the stone or the laser fragmentation. Okay. So, pain of nephrolithiasis will radiate depending upon the location. See, if the stone is in the upper part of the ureter, it will radiate anteriorly. If it is in the lower part of the ureter, pain will radiate to the ipsilateral testicle in men or the ipsilateral labrum in the woman. Okay, and gross hematuria without pain is a feature of your nephrolithiasis. Now, many times other diagnoses are confused with your um, renal colic. What are the other? This is because of the location. Suppose if a stone is lodged at the right pelviuretral junction, it will mimic acute cholecystitis anterior. Suppose if the stone is at the right pelvic brim, then it will mimic the symptoms of acute appendicitis. If it is on the stone is blocking on the left pelvic brim, it will mimic a acute diverticulitis. So like this, or sometimes it can acute renal colic pain might mimic a skeletal pain or a muscular pain or a duodenal ulcer pain or a urethral stricture pain or herpes zoster pain. It can mimic. That's why we need to have the diagnosis. So for diagnosis, we do the serum. What you find in the serum, you'll find elevated WBC. In the urine, what you will find, you'll find in microscopy, you will find increased RBC, increased WBC, and you will find occasionally crystals also. What is the specialized investigation? You have the ultrasound and you have the helical CT scan. Now, helical CT scan is far more superior than ultrasound. Why? Because ultrasound will give you imaging of the upper part of the ureter and the kidney proper. Suppose if the stone is in the lower part of the ureter, it may go undetected. The second reason why helical computed tomography is preferred is that even if the size of the stone is 1 mm, then also it will detect. Those stones which were considered as radiologically translucent, like for example uric acid stone, even those are visible on your helical CT. Also, perinephric standing is visible, which is a sign of recently uh, passage of stone. Even that is shown. So these are all the advantages that we are having nowadays for the diagnosis. Now coming to the reference from the organon, if you look at the footnote number 7 of aphorism number 7, look at this. Hahnemann has told to crush the vesicular calculi. Now, this footnote is often, misinterpreted that Dr. Samuel Hahnemann is advising antipathy. No, my dear friends, Master Samuel Hahnemann has understood that the disease has progressed to the material level. So, a stone which is impacted in the ureter, which is causing hydronephrosis, it is a material cause of the disease. So, here therapy is not required. Homeopathic dynamized medicine is not required. It requires mechanical management of the case. And what we are calling nowadays as the surgical intervention. So Hahnemann sir has advised that when the cause is material, like a stone in the uh, bladder or in the ureter, causing obstruction, then you have to crush it, you have to remove it. Now we come to the very important part, that is the miasmatic classification of the renal colic. See, to understand the character of the renal colic in the homeopathic sense, we have to know what was the condition which was prior to the formation of the renal colic. Then only we will be able to make the choice of the right medicine. So what is a psoric renal colic? The one which is coming sudden in onset, which come with great speed, makes the patient restless, worried. Okay, the psoric renal colic will come after emotional problems, maybe worry in love affair, sad, shock, anger, financial stress, or crisis in workplace. The one which comes with dehydration, with hypoglycemia, with constipation. Okay, A psoriatic renal colic comes together with acute infections like gastroenteritis, influenza, in whom it comes in type A personalities who are highly ambitious, highly active, responsible, fastidious, and industrious. What is the expression? You will have the burning type of pain in psoriatic renal colic with no pathological correlation and associated with fear, worry, apprehension, and anxiety. And these type of people tend to suffer from cystitis, that is fullness in the bladder, tend to suffer from stress incontinence, pass involuntary urination while sneezing, coughing, laughing, as you find in Heparsalf causticum. The frequency of urination is increased in the psoriatic renal colic. Also, your bladder pain syndrome, which we have discussed earlier, is also psoriatic in nature. What are the modalities? Pains. This renal colic will be worse early morning, better by warmth, pressure, and rest. Feel better after urination. Aggravated by noise, aggravated by cold, aggravated by touch. On investigation, you will find increased neutrophils. You will find uric acid might be little raised. Ultrasound will show that there is a stone, but it is less than 5 mm, as was in case 2. Case number 3, we saw that the Kalikab woman with 3 mm stone. Once you give the right medicine, that stone easily passes off. So normalcy return in the psoriatic colic as soon as the stress reduces. So what I'm trying to tell you is the individual pattern of response will guide the physician in identifying the dominant miasmatic state. Now we come to the psychotic renal colic. In whom does it come? Those patients who are don't want to do any physical work, in whom psychotic renal colic will come when you are having excess of purines in your diet, the non-vegetarian with uremia. Psychotic renal colic will come in those patients who are on blood pressure medicines as a side effect of the blood pressure medicines. In those patients who are having predisposition of family history or past history of hyperuricemia, hyperlipidemia, they are having bronchial asthma in the family, arthritis, they are having renal cysts, they are having warts, moles, keloids, okay? Together, renal colic together with, maybe a hernia operation, in the past, or together with a intervertebral disc operation, maybe correction of the nasal septum operation, hysterectomy. After these operations, the renal colic will come is the psychotic renal colic. In whom it come? In this dull, indolent people who cannot perceive, they cannot perceive their symptom. There is absence of symptoms till the stone has grown to a considerable size. Those who are having psychological problem like depressive personalities, who have defective thinking, their memory is difficult, they are yet defiant. The doctor will advise to such patients, follow the diet, but they will not follow the diet. The doctor will advise them investigation. They will not do investigation. Our case too of Pereira Brava, that woman with the fifth episode, yet not bothered about her health. She was having also hypertension, but she was not bothered even of her hypertension. These are the psychotic type of defiant nature they are having. Proud, jealous. What is the expression of renal colic in psychotic? You will have the stitching type of pain, pulsating type of pain, spasmodic type of pain, which is having slow, gradual, insidious onset. Whenever there will be calculi, deposits in the urinary genital tract, you'll have feeling of constriction, screaming while passing urine. This is psychotic type of renal colic. Renal colic because of errors in the metabolism like gout, which give contribution to the deposition formation, along with the acute gouty arthritis. Another thing that suggests your psychotic miasm in renal colic is when you have recurrent episodes with also hereditary load of obesity and hypertension. So, what will be the modalities for psychotic? They feel better by hard pressure. So, I had a patient who developed a UTI after going in the swimming pool with lot of public swimming pool, and he was relieved by wearing the NCC belt very tight. So, relieved by hard pressure, better by slow motion. That is the psychotic relief, and the worsening of psychotic renal colic will always happen during day or at 3 a.m. in the morning. That is worse by wet weather, cold weather. And on investigation, what you will find in the psychotic renal colic, you'll find ESR elevated, you'll find uric acid elevated, X-ray will show calcium oxalate stone, USG will show the impacted stone in the calyces of the kidney, in the ureters, and even hydronephrosis may be found. You will find. What is the recovery? Recovery is generally slow, and chance of complication is higher because these patients don't bother. They don't do the proper follow-up. Okay, and it is for these type of psychotic individuals that Master Henneman has advised to crush the stone to relieve the mechanical block by surgical intervention. Then we come to the tubercular type of the renal colic. How do you get, how does it show? Tubercular type of renal colic will be seen after suppression of ringworm. After suppression of nosebleed, if you get a renal colic, it is tubercular in nature. Such type is aggravated during new moon and full moon. Hematuria will be found and pronounced weakness after passing the urine. Also, these children who have nocturnal enuresis, these are tubercular. Whenever you have mild pyelonephritis, that is tubercular. What the investigation will show, CBC will show leukocytosis and will show lymphocytes and mononuclear cells. Always their blood sugars will be increased. Albuminuria will be found with urine loaded with urates, phosphate, protein, acetone, blood, cast, and sugar. And specific gravity of the routine urine will be increased. If you look at the retina also, you'll find changes of flame-shaped hemorrhage with cotton wool exudates. What is the type of personality in tubercular? These are the thin individuals, but don't think that they are not eating well. They are eating well, but they are having assimilation problem. They may be eating 2 to 3 plates of biryani, but they are not putting on weight. How is their mind? Changeable mood, erratic behavior, restless, and hyperactive accompanied with hypertension. Now, what is the type of pathology? Severe renal impairment with proteinuria and microscopic hematuria. Modalities for tubercular renal colic: feel better in the open, fresh air, although they are chilly patients, want windows open, cannot bear narrow places. They are worse after sleep. They are worse in the morning. They feel better by hot application, better when they are busy, better after bleeding has started, maybe from the nose. How will be their recovery? Recovery will take a long time because their system is weakened and there is lack of reaction. Then we come to the syphilitic type of renal colic, very fast in onset, with stabbing type of pain in connection with rapidly advancing destructive diseases. There will be other destructive diseases in other region, maybe in the CNS, there will be Parkinson's, Alzheimer's, these type of diseases. Emaciation is very marked in the syphilitic type. Initially, you will find suicidal tendencies, destructive behavior like rage, okay? Tendency to inflict harm either on themselves or on others, loses the thread of conversation like chilies, and addiction problem, addiction to drugs, alcohol, tobacco, even to tablets, right? You will have other advanced heart problem in this patient associated with renal colic. Maybe left ventricular failure is there, malignant hypertension will be there with partial or complete loss of vision will accompany such type of syphilitic renal colic. As far as kidneys are concerned, fibrous changes will be found. The urine infection, will give rise to septicemia along with Klebsiella infection. Such patient will be in a comatose state, no sensitivity, process is very fulminating, immunity has fallen down, susceptibility is very low, not responding to any sort of medicines because the pathology is irreversible. And such patients will suddenly worse at night and peacefully die in their sleep because of some perforation inside or some hemorrhage inside. So what are the modalities for syphilitic type of renal colic? They are worse at night, they are worse in company, they are worse by the warmth of the bed, worse by alcohol. But that doesn't mean they will not drink alcohol, they will drink alcohol. And syphilitic renal colic is better in cool temperatures, better, when the abnormal discharges are flowing out, maybe the fistula opens up or a tumor opens up, right? Now, friends, I will share with you some medicines which have been tried and tested for the treatment of renal colic. So the first remedy I discuss with you is your Berberis vulgaris. When will you use Berberis vulgaris? Indicated for renal colic, which in people who are suffering from liver problem and they have taken a lot of medicines for gout and rheumatism in these patients. People suffering from hemorrhoids, this patient Berberis vulgaris will feel lifeless, no desire to do anything. Think of Berberis when the patient developed kidney stone after hemorrhoid operation or after anal fistula operation. It is a left-sided renal colic with bubbling sensation in the kidney. Patient is prone for kidney infection as well as bladder infection, and there will be burning that you will find which comes in waves, so much so that the patient finds it hard to breathe. Pain of such renal colic in Berberis is worse before and after urination, and there is strong backache as a concomitant and sweating from the least exertion. He is a constipated person with sheep dung like stool. And the modalities ameliorated by warmth, ameliorated the burning in the urethra feels better after, during urination. Okay. Aggravation is by sudden movement, by standing, sitting, and lying down. Other second very important remedy is your Arnica montana, the renal colic, which comes from mental shock, maybe financial loss, property loss, or the death of a friend. Colic in arnica is triggered also by injuries of the back, maybe in an accident, or maybe, after a fight with anger, or the colic which comes after excessive physical exertion, or the colic which comes after too much of alcohol drinking. Now, this patient is feeling hopeless and wants to be alone, pushes everyone who is coming to help him. Very oversensitive to pain. He will not talk to you. And during the colic, they will scratch the walls, they will scratch the floor. Patient looks to be completely under shock. Cutting type of pain is felt in the kidneys. And afterwards, there is a wound-like feeling. The bladder feels hurt, pain as if there is a wound. Every strain to urinate will hurt in arnica. Now, concomitant here is chilliness in general with a red hot face and constant sleepiness. This is also a concomitant. And feeling hard, associated with feeling of hardness wherever he's sitting, wherever he's lying. Aggravated by noise, aggravated by touch, aggravated by cold, aggravated by jerking. That you will find in arnica. Better when alone, better when lying down, better by warmth. Third remedy is lycopodium. Lycopodium is a uric acid constitution, very useful remedy for your bladder pain syndrome. Exciting factors for lycopodium is your mental stress, like maybe suppressed anger, apprehension, fear, even heavy foods or the vegetable that produce flatulence is an exciting factor for lycopodium. What type of renal colic? You'll find right-sided renal colic that travels down the ureter to the bladder and begins from indigestion, begins from constipation, must press hard to pass urine. Urine starts in drops with horrible pain before and at the beginning of urination. As the gas is coming out, then he is able to pass urine also better. Drinking even sip of water will bloat up the patient. Tension in the abdomen, cannot tolerate a tight belt, cannot tolerate tight clothes. Colic worse 4 to 8 p.m. Ameliorated by burping, ameliorated by passing urine, passing stool, passing wind, aggravated when alone, aggravated by eating, aggravated by pressure. Okay. The next remedy is your ossimum canum. Now, ossimum canum, you will find right-sided renal colic with saffron-colored urine. Ureter feels wounded. The urine is smelling like musk. Constipation may be there or massive diarrhea and constant bitter vomiting with stitching type of pain. With the modality of better by warmth and aggravated by bending. Since we are talking of bending, I remembered a remedy for the prostate enlargement, which is feeling able to pass urine only when he is standing and bending forward, the yoga position, with the legs slightly spread apart. The remedy which is able to pass urine only in this position, standing with bending forward with the legs little spread apart. The remedy is chima fila. Then we come to Nux vomica. Nux vomica, renal colic. Exciting factors are the dietary factors, the business stress, the financial worries. Nux vomica colic will come after removal of hemorrhoids. Nux vomica thinks the end is near. These nux vomicas will always depend on medicines to sleep. Chilly patient who's yawning and tired, painful, you urging to urine, urine flows in drops, feeling of residual urine, whole abdomen is wounded. Pains are too violent for him, very oversensitive to pain. The pain is making him angry. Nux vomica, these motto is to be able to work, to have a large business, to be more rich, and to be more powerful. Okay, aggravated by touch, aggravated by tight clothes, aggravated by walking, ameliorated by hot applications after sleep, ameliorated after urination, after vomiting, after stool, after rest, after sitting. These are all ameliorating factors. Another remedy I remember for recurrent cystitis, recurrent bladder infections, urinary tract infection is a bowel nosode called as psychotico. Okay, very helpful bowel nosode. So I'm open to your suggestion and queries. Now, one query which has come to me was why Pereira Brava was given in the case 2. See, in case 2, it was a very acute case. The type of modalities which we found in that cannot sit, cannot stand, cannot lie down also. The color of the urine, the smell of the urine, the side, the left-sided affection. So this association of symptoms, this complex, symptom complex, you will find only in Pereira Brava and not in any other remedy. That's why the remedy given in that case was Pereira Brava. The other question that I have been asked is what is your approach for this urinary problem? See, the approach for urinary problem is nothing different than what Master Henneman has given in the organon. It is the organon based practice and the organon based approach that we need to follow in the urinary problems as well. So as we come to the close of this webinar, to conclude, in this webinar, we have seen the different presentations that we find. Acute presentation of case 1, which slowly went into the chronic zone with the miasm lurking. In the case 2, we saw a totally acute presentation in a psychotic patient who takes medicine only for the acute, whereas forgets to take the chronic follow-up because of his defiant nature. And it is such patients who land into complications. The third case is an absolutely soric Kali Carb patient where the stone was immediately passed after the right medicine was given. So the approach for urinary complaints will be dependent on the demand of every case. So in chronic, you will have to go the miasmatic way. In acute, you will have to give the acute prescription, whatever the asoric medicine comes based on your acute totality. So I am very thankful to Homeopathy 360 for giving me this opportunity. I thank my moderator, Dr. Aditi, Dr. Manish Jain, and every one of you, my audience. Thank you and God bless you.